more than a year. So I'm glad you were that the link was able to work. Well, let me welcome everyone. Good morning, good afternoon, good evening, depending on where you are. My name is Kathleen Fischer, and I am president of American Friends, the Alexander von Humboldt Foundation. And it is my great pleasure to welcome you today to the second session of our Humboldt Digital Dialogues on Science, Society, and Politics, today with a focus on culture, society, and policy and health crises, national responses to COVID-19. Before I turn things over to our moderator for the session today, I wanted to go over a few housekeeping details. These, you should be familiar with this too after 14 months in Zoom world. We'd ask all of you to keep your microphone off while we're having the presentations. We do invite you to make comments or ask questions. I actually think, Andrea, we have a manageable number today, so I would like to try and have our participants ask their questions themselves. We will keep a queue, so if you can actually send us to the all message, we'll keep track of that and keep track of the queue for our moderator. We want to try and bring in as many questions as we can today. If you have technical problems, please use the email link, which is being provided to you, and we will try and help you troubleshoot and figure out the problem. And please be advised, as you came on, you should have heard that we are recording the session, so people who can't participate today will be able to view the session later. And we did have people that weren't able to join us the first time and did go back and look at the video. So thank you for agreeing to do that. And with no further ado, it's now my great pleasure to introduce the moderator for today, who's also one of our board members, Dr. Andrea Stiff. Andrea, the floor is yours.
Okay. Thank you, Kathleen, and hello to everyone. I want to thank you for joining us today for what I'm sure will be an enlightening and thought-provoking session. I'm pleased to welcome you to the second installment of the first Humboldt Digital Dialogues series on science, society, and policy, lessons from the coronavirus pandemic. The first session featured American Friends Board Chair Bill Kohlglaser and Professor Anke Höfler, who discussed the key policy, research, and societal questions that emerged from the global response to COVID. If you missed it, as Kathleen mentioned, the recording is available on the American Friends website. But today we'll discuss how culture, society, and politics have impacted the national responses to the COVID-19 crisis. I'd like to say that as a scientist, I've largely viewed this pandemic through a scientific lens and have been reassured by the speed with the understanding of this novel coronavirus has led to rapid testing, viable public health interventions, accurate diagnosis, effective treatments, and multiple vaccines. As a result of these achievements, I remain cautiously optimistic that there's a pathway from our experiencing COVID through the lens of health and societal crises to one of a largely predictable and manageable illness. Still, potential challenges that remain are complex and multifaceted. These include the emergence of new variants, vaccine hesitancy, the lack of uniform vaccine availability worldwide, and fatigue with the guidelines that restrict mobility. These cautionary notes make us realize that we have to look past biology to consider the additional factors that impact the way that communities perceive science and act on scientific advice. Today, we are lucky to have two excellent and compelling Humboldt scholars who can help us understand how science is filtered through culture and politics. I won't give lengthy introductions. Instead, I refer you to the invitation for more detailed information about our speakers. So with that, I'd like to first give the virtual floor to Professor Šumit Ganguly. He is Distinguished Professor of Political Science and Rabindranath Tagore Chair in Indian Cultures and Civilizations at Indiana University. Šumit.
Thank you so very much, Andrea. I am delighted to be able to participate on this panel, and I am grateful to both you and Kathleen for organizing this, and my most abject apologies to everyone for my tardiness in joining this call. It was circumstances entirely out of my control. The computer sometimes has a gremlin in it, and it just happened to choose this morning. Without any further ado, let me turn to my topic, which is India's mangling of the COVID-19 crisis. And I'll make three distinct arguments. First, I will talk about structural weaknesses that existed in the Indian political and social order. Second, I will talk about contingent choices. And third, I will say a couple of words about learning from this tragic experience. At the outset, let me talk about structural weaknesses. And there are three issues that I will highlight. First, for decades, a number of us who have looked at questions of public policy in India, and particularly the health sector, have argued that India has done a woeful job of spending on public health. For a country of its size and significance, it spends less than 1% of its GDP on public health. This was a recipe for a disaster foretold. Second, surveys reveal that long before the onset of the pandemic, absenteeism was rampant in rural public hospitals. And by absenteeism, I'm referring to physicians, I am referring to nurses, I am referring to other ancillary hospital staff. So consequently, you had a rickety, ramshackle, underfunded public health infrastructure. And this was under normal circumstances in the absence of the pandemic. Third, another structural factor which has exacerbated matters are the difficulties of social distancing in a densely populated country, where people live cheek by jowl, especially in overcrowded, turgid urban areas. And consequently, even if you had highly sophisticated campaigns, public information campaigns, urging people to social distance, the practical matter was it was impossible. When you have entire families living in a hovel where social distancing is simply not practical. So all these three things, all these three factors were structural weaknesses that existed both at economic and social levels in India. In addition to this, there were 5 contingent choices that have dramatically impacted on the consequences of this pandemic. And I'll go through them ad seriatim. First, the government of Prime Minister Narendra Modi, in its typical sort of decision-making trend, which is marked by, without any thought about the likelihood of consequences, the government makes decisions in an extremely abrupt fashion with little or no consultation. This has been the case in a number of public policy areas, ranging from the demonetization of high-end bills in the Indian economy, which essentially removed close to 80% of the currency of the Indian economy, to the rollout of a goods and services tax without any preparation of how it would impact mom and pop stores, which are widespread in India, leaving them entirely in the lurch. In a markedly similar fashion, the government chose to impose in March 2020 a 21-day national lockdown, making no provisions for literally 100 million migrant workers who were dispersed across the country. And this was done with 4 hours notice, with no provisions being made for their welfare and no provisions being made to transport them on railway or automotive networks back to their home villages, which were often several hundred kilometers away, leaving them to the tender mercies of India's blisteringly hot summer, which starts by March. Second, no provisions were made during this 21-day hiatus to rapidly acquire vaccines, to rapidly acquire personal protective equipment and ventilators. And this, by the way, you have to place in the background of a public health system, which under the best of circumstances is always on the brink. Third, instead of stockpiling millions of doses of the vaccine to deal with the ongoing pandemic, the government, in an utterly misguided fashion, chose to invest in vaccine diplomacy and sent out millions of doses of the vaccine produced within India, both by the public sector and by the Serum Institute of India, a major manufacturer of vaccines, to neighboring countries and to Africa. Obviously, I can understand the goodwill this generated for India in Africa and in neighboring countries, but this was a colossal blunder when you did not have enough resources for your own population first. Fourth, in an utterly callous fashion, with one eye firmly cocked on electoral results in 4 states across India, the government held massive campaign rallies involving hundreds of thousands of people standing close to one another with no prospect of social distancing, rarely using masks. This was sheer and utter callousness on the part of the government, solely concerned about electoral fortunes without any regard for public health. Worse still, it allowed a massive Hindu religious festival, which takes place every 12 years along the banks of the Ganges River, which typically attracts anywhere between 1 to 3 million mendicants and Hindu committed Hindus who feel that this is a vitally important festival. There were only minimal attempts at social distancing. How do you do social distancing with 1 million to 3 million people? Frankly, boggles the mind. But apart from that, there were literally no mask restrictions, nor were significant efforts undertaken to ensure that those attending were not carrying the virus by carrying out tests on these individuals. These 2 sets of events proved to be super spreader events because within weeks thereof, one saw significant spikes across 4 states and of course the 5th state where this massive religious festival was held. Fifth and finally, to the utter dismay of a highly sophisticated medical establishment in India, a number of high-level politicians and political notables, especially belonging to the ruling Bharatiya Janata Party, chose to propose any number of completely dubious quack cures for the virus, suggesting, amongst other things, that bovine urine is a powerful disinfectant and that bathing in bovine urine would protect one from the virus. Some even went to the extent of suggesting ingesting bovine urine. Worse still, other notables suggested that people cover themselves from head to toe with cow dung. The medical establishment pleaded and begged people not to encourage these kinds of utterly dubious schemes and propositions, but they were disregarded. So all these contingent choices have led India to this tragic pass where close to 400,000 new infections are emerging on a daily basis. Let me turn now to my final point, and that is, will India learn from this crisis? I am moderately optimistic that it will, because there seems to be a peculiar streak in Indian political culture that it undertakes major reforms only in the wake of an existential crisis. And very quickly, I'll give you a handful of examples to illustrate this point. India undertook the Green Revolution in the early 1970s when it was faced with the specter of mass death as a consequence of a famine in the late 1960s. India undertook major defense reforms after a disastrous war with the PRC in 1962, a major program of military modernization. India embarked on dramatic economic reforms in the wake of an unprecedented fiscal crisis in 1991. So there seems to be this peculiarly crisis-driven mentality that is characteristic of Indian political culture. And one hopes that the disaster that this pandemic has brought on millions of Indians and the havoc that it has wreaked across the country will serve as a suitable wake-up call and lead to significant necessary reforms in India's public health infrastructure. Thank you for this opportunity.
Okay, thank you so much, Šumit. I think before we take questions, we'll go ahead and turn to Ted, who is Ted Fischer, who is the Cornelius Vanderbilt Professor of Anthropology and Director of the Center for Latin American Studies at Vanderbilt University. Ted, please take it away.
Thanks so much, Andrea, and thanks, Kathleen. I would like to echo Shumit's points. This is a wonderful forum. I'm a huge fan of the Humboldt Foundation, of course, which is those of us whose work it's supported, we tend to be fans, but also the work of the Friends of the Humboldt Foundation. This is really important. And I think the title of this whole digital dialogue series, Science, Society, and Politics, underscores the power of bringing together a network like this, having a political scientist and a cultural anthropologist talk about public health and virology and why that's important to understanding the problems facing the world today. So hats off for conceiving of this series and in this kind of interdisciplinary way. So my remarks today, I want to talk about a project that I have been working on, that I lead. It started at the WHO's regional office for Europe in Copenhagen, and then the Robert Wood Johnson Foundation wanted to expand it out and tap me to do that. And it's looking at the cultural context of health and well-being. We started this project in January of 2020. We all know what immediately ensued after January of 2020. And so we quickly pivoted to look at the cultural context of the COVID pandemic, which tragically illustrates our core point, that health is not just about biology and medicine. We need these, they're crucially important. We need lab scientists developing vaccines. But as Šumit has just made clear, actually, we cannot understand the COVID-19 pandemic, or really any other health issue, just by looking through a microscope or sequencing a genome. We tend to celebrate that, sort of the lone scientist discovering a silver bullet solution to the problems that we face, but really it's much more complicated. The virus itself, SARS-CoV-2, like all viruses, is inert. It doesn't have a metabolism. Unlike bacteria, it isn't attacking us so much as we are spreading it through our social networks, through our cultural pathways. Again, Šumit gave plenty of examples of this, and the Hindu festival is a great one. People, that is really important, that religious health for many of these devotees was just as important as medical health, as physical health. And we have to take those kinds of things seriously. It turns out it matters what kinds of jobs we have, what kinds of economies we have, what kinds of governments we live under. All of these things make us more or less vulnerable. High levels of social trust tend to inoculate populations against the pandemic, and low levels of social trust are associated with poorer outcomes. So in these ways, well, essentially we are the virus in that sense, right? We transmit it, we give it life. It is us. But these social and cultural and political and economic factors interact with the virus itself, SARS-CoV-2, to produce the pandemic. They are not secondary to the pandemic. They're not incidental to it. They actually work with the biology to produce the outcomes that we experience. And like climate change, and like so many problems facing the world today, it's complex. It's depending on what discipline you come through from, it's multidimensional, or it's systems. We need systems thinking to think about that. It's complex, it's multifaceted, and it requires interdisciplinary and integrated solutions. So in this project that I'm going to report on and give you an overview of a few of our conclusions, we took this opportunity of the pandemic to look around the world. And it's really, I almost hesitate to use this term, but it's something of a natural experiment. We have essentially the same virus. Now there are variants, and that's significant, and we can go into that. But let's give me this: essentially the same virus in different contexts, in different countries, in different governments, in different cultural areas, producing different outcomes. So why is that? It's not just about pre-existing conditions and biological vulnerabilities. It's obviously about these social and cultural and political factors as well. So in this work, what we did was we looked around the world at different responses to the COVID-19 pandemic and tried to pull out some lessons, because this is not going to be the last public health crisis facing the world. It's probably not going to be the last. It's not going to be the last viral pandemic. It's not going to be the last sort of crisis of this sort. So we really need to not only be rolling out the vaccine and getting people inoculated, we need to be thinking about next time and thinking about how we can institute long-term solutions that will make us more resilient. So I want to give you a few of the lessons and some examples from it to give you a sense of the kind of thing I mean when I say the cultural context are really, really important. First, the cultural models we have of the virus, the ways in which we conceptualize it, the ways in which we talk about it, affect the way in which we respond to it. And in fact, politically, they affect the ways we respond as much as the science does in some ways. And so I think it's problematic to see the virus in political rhetoric as a foreign invader that can be killed or that can be vanquished. In fact, I just mentioned viruses aren't alive by most measures of what we would consider to be alive. And so killing it, maybe we need to think about how we live with it. And this is really the way the Navajo, the Balinese, many cultures around the world would see this as a problem of learning to live together rather than trying to fight. And really, this is, I think it's been problematic in the communication around the virus as well. The only way out of this is we're going to incorporate SARS-CoV-2 into our biome, into our biology. And that can be through exposure or it can be through vaccinations. But we're going to have to learn to live with it. Vaccinating isn't killing the virus. It is protecting us against its ill effects. And so what are the implications of that? So using war metaphors, as many countries have done, including here in the States, can heighten xenophobia. the China virus, the Wuhan virus, and look at the rise in anti-Asian sentiment that we've seen. And this can make marginalized groups even more marginalized and vulnerable. And this is really one of those situations where if someone is vulnerable, we're all vulnerable. And this is a sort of a footnote, but this is the reason why global rollout of the vaccine is so important. If we have big pockets of unvaccinated people, new variants are going to be popping up that we're not going to be inoculated against, and it's going to make us vulnerable as well. I hesitate to use those self-interested metaphors because I think it's just the right thing to do. But sometimes we have to argue that it's the right thing to do because it will protect us as well. Some countries, including the Netherlands, for example, leaders have chosen other metaphors. Running a marathon, for example. We're running a marathon. This is not something that's going to end tomorrow. It's not something we can kill or get rid of. Others have used wildfire or glitter or malware. There are other ways, but my point is the way in which we talk about the virus influences the way in which we react to it. The second point, cultural values really matter in the response. This is a situation where relying on individual choice is insufficient. We have to have a coordinated response, be that wearing a mask or social distancing or vaccinating. Places with higher levels of social trust and solidarity, including Northern Europe and East Asia, have tended to do better. This isn't uniform. There's not a one-to-one direction. This is definitely not to say that some societies have good values and some societies have bad values. Rather, cultural values are mutable. We can frame these in different ways. So, for example, the Dutch Prime Minister, Mette Frederiksen, has resurrected a somewhat archaic Danish term, the Danish Prime Minister, samfundsend, which means sacrifice for a common good, and use that in saying this is a core Danish value, and this is what justifies masking and social distancing and closing schools. And so, and in the same way, we often think, oh, well, you know, we're never going to be Scandinavia in the States. So what can we do? We just have different cultural values. But we have a range. Picking yourself up by the bootstraps is one, and having everybody make individual decisions. We also have cultural narratives about barn raising and communities coming together. And let's throw a show and raise the money. And so the way our leaders frame cultural values affects the way in which we're collectively able to deal with or not deal with these problems. This is really acute in terms of the vaccine rollout, I think. A lot of vaccine skepticism and hesitancy and anti-vaccine activism is not based on a lack of good information or of scientific information. That's not, there's plenty of misinformation going around in social media, and that is part of it. I absolutely agree. But this is also core to people's identities. A skepticism of big pharma, it's not actually irrational, right? An anti-authoritarian sentiment. And so when we're dealing with anti-vaccine or vaccine skeptics, rather than just trying to hit them over the head with science is right and you need to submit, or here are some more studies that show why we're right, I think we need to engage with them at the level of values. And what are the values that we share? We want the best things for our kids, and to start a productive conversation in that way. We looked at several other elements. Community trust is really, really important. The impacts on mental health are significant and growing and sort of feed back into these loops. But let me just say that our overall conclusion is that the COVID-19 pandemic is an acute problem that we're facing right now, but it results from chronic issues. And again, it's the interrelationship of urban planning and public transportation and economics and the kinds of jobs people have and government regimes and social welfare or not states and cultural traditions and social networks and all of these things working together. And so while the vaccine is absolutely crucial and we need to be supporting global rollout, It is not the only solution that we need. And to come back to the point I made at the very beginning, I see a lot of potential in networks like the Humboldt Network that bring together people from different disciplinary backgrounds and perspectives to tackle common problems like this. And the world needs more of this, because there are very few problems that we're facing where we're going to find a silver bullet solution. We need long-term structural kinds of changes that are informed not only by hard science, but by social science and those of us on the softer, softer side of the academy. Thank you very much.
Okay, thank you so much, Ted. So what we'll do now is go ahead and open the floor to questions. So as Kathleen mentioned before, if you want to go ahead and type your name in there, we can call on you in order. And you can go ahead and unmute yourself and ask the question yourself. And so while you all are doing that, maybe I'll go ahead and just ask each Šumit and Ted a question, and then we'll move on to the audience's question. So Šumit, I have just one question for you. You talked about the, historical aspects of India's response to crises, and kind of incorporating that into kind of changing their ways in the future. But I have one question about India's history, as far as the plagues that they experienced in 1896, and then the flu pandemic in 1918, 1919. Are there any, how have these historical experiences maybe impacted how they dealt with COVID today? Is there any of that to be seen? You're on mute.
The two instances that you cite took place under the British colonial era. And interestingly enough, the Epidemic Act, I believe, of 1895. I'm sorry, there's some strange alarm that is going off. It's some sort of emergency alert in my county. I'll discount it.
Be careful there.
Oh, we live in a sturdy house. We'll be fine. I believe it's the Epidemic Act of 1895 or 1896, which amazingly enough still exists on the books in India. It's been modified a couple of times since in the last 2 decades, but it gives the state extraordinary powers to quarantine people. And that's how that lockdown was possible on the 21-day nationwide lockdown was possible, because once that act is invoked, it gives the state incredibly powerful tools that it can apply. Now, this is no surprise. Colonial powers invariably wanted an extraordinarily strong executive with little or no legislative oversight. And to some degree, that came into play, and it's still being utilized at the state level in India, where states are imposing local lockdowns, invoking the Epidemic Disease Act. The one other point I would make is that India has done a reasonably good job in the post-independence era of dealing with endemic diseases like smallpox and cholera. They have both, of course, smallpox has been eradicated, as we know, and cholera, for the most part, is no longer a problem. I remember as a child every year being subjected to the awful cholera vaccine. Just the sight of the needle made you cringe. But anyway, for the most part, that's been significantly controlled, and smallpox has been eradicated. India did a very good job with tackling AIDS. But the problem here is with AIDS, you could, there was prophylaxis available, and you could engage in a massive nationwide campaign. The difference here is that even if you had a massive nationwide campaign, there were structural problems that inhibited the controls over this virus, as I have tried to explain. With AIDS, it was simply a matter of changing behavior and basically inducing people to use condoms, and which were readily and cheaply available. And consequently, the crisis was contained.
Okay, excellent. Thank you so much. And then Ted, I just have one quick question for you, just about perhaps the experience of Sweden in the crisis and how, to my eye, they took a different different tack than most other countries. And I was just wondering if you could comment on some of the cultural and social things that led to that, and then maybe some insights into how effective that was. And
it's a great question, and I don't have a good answer. We think of Scandinavia and Northern Europe as being homogeneous that way, and they're very, very different. The jury may be it may be too early to see what the long-term impacts of that are. Could I pivot and sort of answer your question to Šumit as well? Because as you were saying that, it occurred to me, just since we are in a Humboldt forum here, that a lot of these ideas about medicine being integrated really began in Charité and in Berlin with people like Rudolf Virchow back in the late 19th century. And so in some ways, this is coming back to things that are that started in Germany and sort of public health interests that way.
Excellent. Okay, thank you. So I see that we do have a question from Wolfgang Litka. So if you'd like to unmute yourself and go ahead and ask your question rather than my reading it for you.
Yes. Hello, good morning. I'm Wolfgang Litka. So I asked a question to Šumit about, giving us his take on differences between India and China, and neighbors, and clearly affected by the pandemic, but very different response of the society, the government, and also different outcomes. And so with the different cultures, different governmental systems, etc., that was something on my mind. I found very fascinating, giving deep and insightful synopsis that we heard from Šumit. And he already answered. Maybe he can summarize for everybody his take, which is very interesting. And I would just volley back. I would like to hear from him about his opinion on does he view the pervasiveness or remnants of the Indian caste system of playing into this, and also prevailing religion, as he already has alluded to, and compare the influence of religious attitudes and religious beliefs in India versus China, and how that has played out, how these countries, societies, and cultures have dealt with SARS-CoV-2.
Yeah, I can answer this question. I've privately written back to Wolfgang, but I'll share this with everyone. The first and most important difference is that significant coercion and thereby compliance is possible in the PRC. India is a deeply flawed democracy, and I've written about it ad nauseum, and especially in the recent past, both in popular and academic circles. That said, coercion is extremely difficult in India. And people will push back because that's the nature of India's political culture. It's messy, it's disorganized, but people don't respond well to government coercion. In China, you can issue a dictum and it will be followed because there will be consequences. The Indian state, first of all, is not so organized, and nor does it have that coercive capacity. So that's one fundamental difference. And furthermore, it has created over time a political culture where of sort of rampant individualism in India, that I can do pretty much whatever the hell I please because I am a citizen of this country and that's my sovereign right, even if I behave stupidly, not unlike in the United States. So that's one vital difference. Second, China has a decent public health infrastructure, which it put in place even during the Maoist years. India, on the one hand, is a hub for medical tourism. You can get your hip replaced for about 1/5 of the cost in perfectly modern, hygienic, sanitary conditions at a hospital in New Delhi or Bombay. And at the same time, you can go to a public hospital barely a kilometer away, and you will get a glimpse of Dickensian England. So there are two worlds in India. One which people like myself with my dollars can access, or my fairly affluent family in India can access. And then the vast majority of India's population who are left to the tender mercies of a shambolic healthcare system. China, it's not like that. In China, there is basic healthcare available to all and sundry, and they were much better prepared thereby to deal with this pandemic. The caste system, yes, the caste system is almost coterminous in India with social class. And consequently, if you are a lower caste person, chances are your social class is also quite low. And thereby, you bear the brunt of any calamity, whether man-made or otherwise, because you are socially vulnerable. And this is a colossal tragedy in India. India has tried to ameliorate it through a massive, the world's largest affirmative action program, which has created a creamy layer of lower castes. But for the most part, discrimination in India remains rampant. And you know a member of a lower caste by his or her last name. And unfortunately, prejudice and discrimination remains sort of the warp and woof of Indian life.
Great. Okay, thank you, Šumit. I think I will move on to allow Katrine Amian to go ahead and ask her questions.
Great, thank you. So here I am. I'm Katrine Amian from the Alexander von Humboldt Foundation, the head of division for North America and Australia, New Zealand, Oceania there. And I was intrigued by the role of trust that both of you, I think, indicated or mentioned at some point. And Ted, I took note of your sentence, "We are the virus, it is us." So in a way, that's nerve-wracking if the virus is your neighbor. And so it kind of that undermining of trust in the people who are socially near to you is, I think, a phenomenon that we've all been experiencing during this time. And so I sometimes wonder, where we will go from here and what the impact will be for the next few years with that experience. And maybe Šumit, to the situation in India, the few voices that we've been hearing that have reached me from our Indian Humboldt network also indicate there's a big trauma now. I mean, so many families are really hit by the last COVID wave and have lost relatives, and kind of that loss of trust in that, if you're educated and somewhat are doing well in India, that you can buy healthcare and find your way, and that this is really a traumatic experience, that suddenly that's not possible, and it's not possible to get your parents into a hospital. So it seems like that notion of trust, which is so important to the Humboldt Foundation of building bridges of trust, seems to be a bit shaken now in the pandemic in various ways. And I wonder if you have any thoughts about that, on what that might mean for the future.
Absolutely. Thanks for pointing that out. And it's a hard thing. I think very often in the public health world, we assume that we are trustworthy, and thus people should just trust us because we're trustworthy. Where in fact, trust is something that is, as we all know from our individual and personal lives, something built up over time. It's hard to gain and it's easy to lose. And so showing up in a crisis, it's showing up after the fire has started and asking people to trust us, right? And so one of the lessons for me from this is we need to really build up trust, especially with marginalized communities, ahead of a crisis. And that requires, to receive trust, we actually have to give trust as well. And there are some interesting examples that have come up in the pandemic. In British Columbia, for example, the public health officials issued 8 principles that they wanted communities and organizations to adhere to, but trusted them to come up to operationalize those and come up with solutions that were locally appropriate and fit with their organizational or their community culture. And so by giving trust that way, it's also points to the importance of history. In the States, the history of the Tuskegee experiments most famously, but other sorts of experiments like this have undermined trust in public health authorities in a way that we can't just say, hey, this is for real this time. Or you know, we captured bin Laden, the CIA, doing this in Pakistan under the guise of a vaccination campaign. And this has come back a little bit in Pakistan now to haunt us. And so we can't abuse trust and then when we really need it, say, hey, no, really, this time we're trustworthy. You've got to trust us. And so I would say that underlines the sort of the long-term project in this. And one final example I want to give is Vietnam did really well, especially early days in the viral pandemic. Vietnamese people are not especially trustworthy of their government. And with good reason. But the Vietnamese public health authorities used social media, put out information as it came out, were very open and transparent about the information, and it seemed to work. And so openness and transparency really do work. And so rather than trying to game what people are ready to hear, perhaps in public health communication, we could think more about how do we explain the evolving nature of our understanding, and that our recommendations may change over time as more and more data come in.
Okay, thank you, Ted. Šumit?
Yeah, thank you for the question. At the outset, let me say that social trust in India is actually quite low to begin with. And there are a couple of different reasons. One, it is a deeply riven society. It's riven by differences of caste, differences of social class, and differences of religious affiliation. So to begin with, there are significant cleavages that already existed in Indian society. You are much more likely to trust someone who belongs to your same social class or your caste group, because there is solidarity amongst caste and class memberships. That's one. Second, there is a problem in India which has long existed, in that even though the government comes up with grand schemes, its actual ability to implement them leaves a great deal to be desired. And consequently, there is mistrust of government in India. It's not so much like in the US, where there is this conservative fear of government intervention in our lives. And of course, there are contradictions there because conservatives are perfectly happy to regulate the bodies of women. But let's leave that aside for the moment. The point is that you don't have a great deal of faith in government when government comes up with grand plans, but its actual implementation leaves a great deal to be desired. So consequently, at two different levels, both social and institutional, trust is weak in India. And you are absolutely right. If this pandemic has brought home anything, it's that wealth is no shield. A friend of mine who was the head of Lockheed India came down with COVID. His wife contracted it. They got access to the best possible healthcare in the world because money was no object. And you have superbly trained medical personnel. He barely survived. His poor wife didn't make it. This has driven home to the wealthy that for once you cannot build walls and be in walled communities, which are widespread in India, by the way. That, okay, the power supply doesn't work. We have our own captive power. You can't rely on the local police. We'll get private guard services. You don't want to go swim in the local pool because it's not properly chlorinated. We have our own perfectly chlorinated pool. And there has been a retreat on the part of the Indian upper middle class into these enclaves. And suddenly they have discovered that these enclaves are no longer safe, that the virus can breach any wall, literally and figuratively.
Excellent. Thank you, Šumit. I would say we have about a little less than 5 minutes to go. So I'm going to try and squeeze in these last two questions, and then I'll give Ted and Šumit a chance to make a final statement before we close out. So let's see, Bill Colglazer, you had a question. Would you like to go ahead and ask it?
Yes. Thank you both for very interesting talks. I enjoyed listening to you very much. I have a question. One thing that is interested and somewhat perplexed me, some of the I'm looking at advanced countries in science and technology, and some that did well in 2020 have not done so well in 2021. I mean, the ones that did well in 2020, like Taiwan, Japan, parts of the EU, and they were very slow in 2021 to roll out new vaccines and vaccinate the population. Then you had the US and the UK that did poorly in 2020, did much better in the rollout. Now, those countries that had a lot of social cohesion maybe did well early, but perhaps the individualism of the US and the UK and sort of the innovation and getting new vaccines worked well in 2021. So I'd be interested in your perspective on those two different categories.
That's a fascinating observation and question. And yeah, it points to the danger of calling winners too early in something like this, right? We would have held up Germany as a paragon of how to deal with this. And I think you're right, there's something there. The social cohesion, which very often goes along with a strong welfare state and sort of trust in institutions, is not as nimble. Those countries seem to be not as nimble in the way in which you pointed out, politically, economically. And so I think that there is something there, sort of the high levels of solidarity doing well in the non-pharmaceutical phase of intervention, and then the others not. Really nice comment.
Okay, Šumit, did you have anything to add, or?
No, not really. I think Ted's done an excellent job of summarizing it, and I'd rather cede the time for other questions.
Excellent. Then I'll go ahead and let Ilonka go ahead and ask her question. You're on mute, Ilonka.
Apologies. Professor Fischer, did you look at Japan in your work? I think it's such an interesting case, the way things have unfolded. And now we see protests against the Olympics happening and very high levels of vaccine hesitancy, but you have a population who's culturally used to wearing masks and is, compliant and listens to their government officials, and is also a country where hand washing and sanitizer and things are common and were common well before COVID. I was just curious to hear your thoughts.
And I don't really have any beyond I think your observation is really on point. It's right. Japan is really this enigma right now for the reasons that you pointed out. And I don't have any special insights, I'm afraid.
Thank you.
Okay, then Nachiketa, can you go ahead and ask your question quickly? Sorry.
Yeah, no problem. I had two, but I can ask one if there is possibility of time. The two questions for whoever wants to take it is how effective is scientific literacy in sort of shaping response from society in particular, and indeed policymakers, because sometimes they are not always as literate as you'd hope. The second point, connecting to Ted's point, that you can't always get everyone on board, hitting them with more scientific data and studies. Well, what do you do then? What's the alternative to that?
Ted, do you want to go first?
Go ahead, Šumit, that would be great.
In terms of scientific literacy, there's absolutely no dearth of that in India. India has a highly sophisticated scientific establishment ranging across a whole host of fields. But if you have a populist leader who has authoritarian inclinations and who is impervious to scientific knowledge, not unlike a certain president we had recently in the United States, there isn't a whole lot that can be done. It's not as if the Indian Council on Medical Research was inept or did not proffer adequate scientific information and advice. But if you have a prime minister and his acolytes who believe in Vedic science and the like, and who are willing to pander to certain elements of the obscurantist population, purely in the quest of electoral advantage, no amount of scientific expertise can breach that particular wall.
And I don't have a neat answer to your question, although I think your suggestion is right, that more narrative or more humanistic forms of communication combined with the science can be really effective. It makes a big difference. Earlier in the pandemic, it made a big difference if someone knew someone who had been seriously ill or who had died, how that affected their behavior. You can sort of emulate that a bit through narrative, I think, in a way that the stats alone just can't do. And I want to underline that I think the science and the statistics and the data, that's all really important, but it needs to go along with these other things.
Thank you.
Okay, thank you so much. So I know that we have run over by a couple minutes, and so I want to thank everybody for your patience, for bearing with us, and for sticking with us. I really feel that this was a fantastic session, and I really enjoyed hearing from Ted and from Šumit, and also really appreciated the participation of all the participants, and for asking such really excellent questions. So with that, I'll kind of, I'm going to stop talking and just give Ted and Šumit just a quick moment to make a final comment, and then we'll let you go on with your days. So Šumit, go for it.
Thank you so much, Andrea and Kathleen, and to the staff of the Friends of the Alexander von Humboldt Foundation in the United States for making this possible. It's been an absolute delight to be able to present some of my recent work on the subject. And I was delighted by this array of thoughtful and penetrating questions. And I hope that we will have other occasions, perhaps at a more felicitous moment, to convene once again.
Thank you.
Agreed. I would just second everything that Šumit just said, and to say that right now we're talking a lot about recovery, and we're all eager to get back to normal. but we don't want to recover exactly what we had before. We're also in a moment that some historians would call a plastic moment, where things are up in the air, systems can change. And I hope that our eagerness to roll out the vaccine and to get back to normalcy doesn't make us lose this opportunity to make the kinds of structural changes that we need to be better prepared for future emergencies.
Wonderful. Great points, both of you. Thanks, everybody. And we look forward to seeing you at our third installment of the series. So have a great day. Thank you.
Thanks, everyone.
Thank you, Andrea. Thank you, Ted. Thank you, Šumit. Great.